Thank you, everyone. It's a pleasure to be here. I'm going to be talking today about the non-medical use of prescription medications and also the medical misuse of prescription medications among adolescents. Specifically, I'm focusing on opioid analgesics. And of course, I have a research team. Some of them are here today, and I want to thank them for all their help in the studies that I'm about to present. We have funding from NIDA, and the team is funded from a variety of sources, and this is the funding that we received. And I have no conflicts of interest to report. My purpose today is twofold. I will briefly look at some of the trends and prevalence estimates for this age group, but we've heard a lot about that already. That was the big picture. I'm going to winnow down now and talk about the heterogeneity among adolescents who abuse prescription opioids and other controlled medications. We like to think of the prescription drug abuse problem as a monolithic problem, or that we understand what we mean when we say prescription drug abuse. But indeed, I'm going to argue today that it is a set of very diverse behaviors that have implications for prevention and for treatment. So a little background, and this will be quick because we've had some great background already. We know that controlled medications are widely marketed, they're efficacious, and they're often prescribed, and they're very common in household. In fact, one of our studies, we found that 75% of adolescents had access to controlled medications that were unsupervised. So they're very easy to get a hold of for this age group. Emergency room visits, overdoses, and transition to street drugs are all related to prescription opioid analgesics. 22% of high school seniors in the United States said that they had used a controlled medication without a prescription. And the NSDA estimates the annual prevalence for PDA, which is my acronym for prescription drug abuse, in adolescents is almost twice the pooled prevalence of cocaine, heroin, and methamphetamine combined. But we have to come to terms, because I just talked about the heterogeneity in this group. And what we have is we have prescription drug abuse, and then we have all different kinds of behavior that are related to it. For instance, we have sensation seekers who don't have their own prescription. So this is somebody who is a high school senior, and these are all scenarios that from our study. High school senior, she's a partier, a friend gives her OxyContin, and she snorts the OxyContin. And she's doing it to party and to get high. So she's clearly using the opioid analgesic for sensation seeking. But we also have adolescents who are using opioid analgesics without their own prescription, but they're using it to self-treat. So an example will be a young girl who gets 20 hydrocodone tablets for her third molar extractions. That's common to get 20. She only uses 4. They hang around in her house, and then when she has menstrual cramps, she self-medicates with the opioid analgesic. But she's also a prescription drug abuser. And then we have sensation seekers who use their own prescription. And these are adolescents who have a prescription for an opioid analgesic, they also may have had them for a third molar extraction or for an injury, such as a sports injury. And when they are no longer using those pills, they use them to get high or to mix with other drugs. And this is also a common practice among adolescents. And these are sensation seekers, but they're not using diverted pills. They're using their own that they have left over. And then finally, we have a group of adolescents that are self-treating with their own medications. And these are a worrisome group as well, particularly for a nurse, such as myself, because this group may not be getting the appropriate treatment for their pain. So this is a group of adolescents who have prescription pain medicine, an opioid analgesic, but they're increasing the doses, not to get high, but they're increasing the dose to cover their pain. Every single one of these, though, counts as a prescription drug abuser. And we lump them in together in our national surveys with our questions like the NSDA questions and the NESAR. So we fail to distinguish between these adolescents who are engaging in all these 4 different kinds of behaviors. So my colleague, Sean McCabe, and I developed a typology based on some early work we did for NIDA. And we came up with these categories of adolescents who use drugs, who use prescription opioids as well as other controlled substances like stimulants, benzodiazepines. And what we said is, or what we asked is, are there differences? Does it matter whether someone is self-treating with their own medication or that they're getting high off their own medication? Now, we can say probably does matter, but we weren't sure, and we weren't exactly sure what we were going to find. So we wrote R01, and we designed studies to test this typology, to see if actually the outcomes are different and the risk factors are different based on the motivation to engage in non-medical use or medical misuse of an opioid analgesic. So what I'm going to do now is I'm going to review 5 studies that were all that are all aimed at looking at that typology and distinguishing between these users, these different users. And they come from 2 NIDA-funded studies that I got to specifically look at this typology. But I had a lot of collaborators on it, some in the room. So you will see for each study, I have listed the citation so you can go to the actual article because I'm going to give you tidbits from it. I don't have time to do it all. So let's talk about the key definitions first, and these apply to all the studies. When I talk about medical misuse, I am talking about an adolescent who has their own prescription, but they're not using it as it was intended to be used. When I talk about non-medical use of a prescription opioid, I'm talking about the use that the adolescent is using that medication and it wasn't prescribed to them. So it's diverted medication. Now that diversion is a felony. They usually get it from friends and family members, but nonetheless, it's diverted and they don't have their own prescription. And then we also have a definition for diversion here, which has to do with using someone else's medication, as well as it can also involve drug dealing, doctor shopping. Now, for all 5 of these studies, we used a sample from 2 school districts, 5 schools. It's a longitudinal study. And again, we were looking at what about these subgroups? Are medical misusers different than non-medical users if they're all self-treating? So the first school district, I'm calling the Selberg district. And this was a school district that is an upper middle class district primarily. You can see that unemployment is low. Many of the kids most of the children are not on free lunch programs, and they're considered low poverty schools. And this school district is a school district in the state that does have a heroin problem and that did report an opioid analgesic problem. We also have the Fernridge Schools, and this is an interesting district. This is primarily a working class district. It also has a charter school that is 100% Detroit students. So this is a very diverse school district. And you can again see the characteristics. Most of the students are on free lunch programs, and it is much more diverse in terms of race and ethnicity. And these are the characteristics across the waves. You can see that we had about even distribution on sex. We had 64% of the sample was white, and then you can see the grade distribution. And we used the secondary student life survey. We had originally developed this in 1999 for college students, and then we modified it for high school students and middle school students. This is a web-based survey that is administered to all the students in the school who we had consent from. The advantage to web-based surveys, particularly when you're asking about risky behaviors, is that you have a better opportunity for controlling what the kind of information that students, particularly young students, are seeing. So for instance, if you're interested as to whether somebody is snorting their hydrocodone, you really, if it's a paper and pencil test, a kid could be reading those questions and say, really, you can snort hydrocodone? I didn't know that. But there's an idea. But when you have a web-based survey, such as this, first you ask, have you ever used, pain medicine without a doctor's prescription? And you start going down, and they never see the questions that particularly put them at risk for thinking of something new. So we really believe that this student life survey, which is web-based, we've been administering it since 2003, as young as 3rd and 4th grade, one that was modified, but it's really designed for middle school and high school. And you can see here that it's web-based. It takes about 25, 35 minutes. We created longitudinal data from the cross-section. I'll be reporting a little bit on that. And there was a panel cohort of 7th and 8th graders who we interviewed every semester for 4 years. And we were interested in finding out where their medications were stored and what kind of prescriptions they had, what they thought about them, how often they were approached to divert their medications. And so that was embedded also in this longitudinal study. The secondary student life survey includes instruments and measures that allow us to compare our sample to national samples. So we use monitoring the future questions. We also use YSR questions. We have the DAST and the CRAFFT embedded, which are screening for potential alcohol problems and drug problems. Now here are the questions. So one of our complaints, if you will, about the national studies is that the questions that they ask do not allow us to ever determine whether we're talking about using your own medication too much or whether we're talking about you using somebody else's, that is diverted pills. So we very carefully tried to be as careful as we possibly could. We wrote questions that allowed us to tease this out so that we could tell whether people were using their own medications or using someone else's. So this was the medication stem. And obviously we were not interested in over-the-counter medications. And the medical use question, this is how many times in your lifetime, and we also ask about past month, have you been prescribed? And in this case, it was the opioid analgesics. We also ask about the other 3 drug classes of controlled medications. One thing we do know is that when adolescents are misusing controlled medications, they're often misusing other categories of drugs as well. And then the non-medical use question was how many times, on how many occasions have you used this medication, in this case, the opioid analgesic, not prescribed to you. And we also asked about diversion. So very interested in whether youth were how they were getting their pills, whether they were being sold them, whether they were borrowing them, whether they were renting them, whatever it was that they were doing to get pills for pill counts or for their own use, how was it that they were getting them? In earlier work, we had discovered that there is a gender difference with diversion, and that is that girls are more likely to divert their pills to a friend to help them cope or to help them with pain, and boys are much more likely than girls to sell their pills. So there are gender differences in terms of how these drugs are getting distributed, and I would argue that means that there are also differences in how we're going to prevent it, and we're going to talk to adolescents about it. And then for the analyses, we created binary variables, and you'll start seeing the data now. Okay, so study 1. This study, we wanted to know to what extent what is the extent of medical misuse of opioid analgesics by adolescents. We also wanted to know about misuse that was associated with other types of prescription drug abuse. And then how is misuse associated with other substance use behaviors? I'm going to draw your attention away from the opioid analgesics. Now, admittedly, that's what we're supposed to be talking about today. But one striking feature of our data is that, yes, adolescents are using opioid analgesics and they're medically misusing them, but they're also medically misusing other drug categories, including the sleeping pills and the anxiolytics. And what should be really worrisome to all of us is that when they're mixing these pills, they really can get into trouble. And we know that adolescents are at great risk for if they're misusing one prescription, they're also at risk for using and misusing another prescription. So you can see then that we're asking about any medical misuse, which is the black bars, and then also were they taking too much of their medication or were they intentionally getting high with it? And while that was in most cases sleeping pills, they're very small cell sizes. And in many ways, you can look at those opioid data and be concerned. We also were interested in substance use and whether medical misusers were at greater risk for having other substance use problems. Remember, we're thinking of medical misuse as a form of prescription drug abuse. However, they have their own prescription. So in that sense, it's not that they're using diverted pills. And we found that in contrast to those who have their own medications and use them correctly, that we found that medical misusers were at greater risk for past year marijuana use, non-medical use of other medications, binge drinking. Indeed, they begin to look like youth with other problem behaviors that are related to substance abuse. And these are medical misusers who have their own prescription. For study 2, we were interested in the diversion. That is, where are they getting their pills and what are they thinking about when they're getting them? And is it associated with other types of substance use? That is, if I ask my friend if she has some Vicodin, some Vikes, am I, just as an individual who is asking to use somebody else's, is that a proxy or is that a warning or a red flag as to whether I myself may have substance abuse issues? And what we found is that the prevalence of diversion by drug class, and this is, as you can see, it's approach to divert their own medications, and then whether any diversion actually occurred. So for pain medication, and I'm having trouble seeing, so I'm going to look down. So what we see is for lifetime pain medication, we see that about 15% of adolescents were approached to divert their pain medication. Now, that is in contrast to the stimulants. And we know that among adolescents and college students, and this is robust, these findings are robust, that about 1 in 3 and 1 in 4 are approached to divert their stimulant medication. And it is lower with opioid analgesics, but it isn't low enough. What it means is that when adolescents have that prescription from the oral surgeon for their Vicodin or their Tylenol number 3, that their peers, once they know it, they are being asked to divert it. And we also realize that when they're diverting it, they also are at risk for other substance use behaviors. So that this is the function of the diversion. For those who divert, they also demonstrate themselves that they have higher CRAFFT scores, which is a screener for potential alcohol problems. They're more likely to have positive DAS scores, which is potential for other substance abuse problems, and they're using other substances. So we're starting to get a picture now. We now see that medical misusers, even if they have their own prescription, are at risk for substance use. And we're seeing that those that are approached to divert and those that actually divert are also at risk for being substance users. So these behaviors do form a sequelae of problems that are related to substance abuse. The third study then is, are there gender differences in opioid analgesic misuse? Who gives non-medical users their opioid analgesics? And what are the motives for non-medical users of opioid analgesics? So now we're moving away from those youth who have their own prescription to those youth that are using somebody else's. These are non-medical users. What we see is that overall, there's a statistically significant difference between males and females. And again, we see that females are more likely to be prescribed an opioid analgesic, and they're more likely to be using them medically in this age group. We also see that girls are more likely to report that they're using non-medically for pain relief only. So when I talked about that typology and those that were using opioid analgesics to self-treat, they're using somebody else's, but they're using it to self-treat pain, then those are more likely to be girls than boys. An example of this, again from our data, was we had a young girl who told us that she had used a Vicodin, actually, from her mother who had had a hysterectomy, and she had a migraine headache, and she wanted to go to homecoming, and she didn't feel well, and her mother gave her the Vicodin. She said she had a great time at the homecoming. It treated her migraine. What we should worry about is, A, she's not getting treated correctly for migraines. That's number one, right? Number two is she was going to homecoming. Was she going to drink with those opioids? And you can imagine all those scenarios. And yet, time and time again, we talk to parents who divert their opioid analgesics to their family members, thinking, just like those girls I talked about earlier, that they're helping their family members. They're not selling them. They're not doing it for nefarious reasons, but they are putting their children at risk, and they're exposing them to these opioid analgesics. So now we have, these are sources. So if someone's source is a parent or a family member, which is over on the, it's over here on my right, you can see that their likelihood of having a positive CRAFFT score, that is to screen positive on this screener for alcohol problems, lifetime, that it's not nearly as great if it was a parent that gave them the opioid analgesic. But if you go to the middle bars and you look about when a friend is giving them the opioid analgesic, then it really jumps up, and this child looks much more like somebody who's going to be getting in trouble with drugs and alcohol. That doesn't mean we should be an apologist and say, well, it's really okay if parents divert these pain medications or benzos or whatever it is that they're diverting. That's not what I'm saying. But what I am saying is that these groups are different, and if we're going to prevent the problem, we need to think about how we're going to talk to parents who are diverting them versus adolescents who are diverting their pills, and how we're going to talk to the youth that are receiving the diverted pills and what their motivation is. And when I speak of motivation, we can see that motives matter, and that's not surprising. That is that experimenters with these opioids are significantly more likely to have positive CRAFFT scores than those that are using for pain relief. So source then and motives do matter. In the fourth study, we looked at, does misuse of prescription opioids lead to future misuse? So the data have been somewhat equivocal on this, and that is that if you talk to even adults who admit to engaging in non-medical use of a prescription opioid, that is, they're using somebody else's, what do they look like at time 2? And we have some evidence that they are more likely to show some substance use disorders, but they also, most of them, have stopped using the opioid analgesic. So is that also true for adolescents, we wondered. And what we found was that to some extent, it is true. And that is that when you see, and again, I'm drawing your attention to the non-medical use for pain relief only. So this is a group at time 1 that said that they were using the opioid analgesic only for pain control. And what you see then is that in general, about 22% then were at time 2 also using it for pain control non-medically. But it also means that quite a few had stopped using it. Where we can really worry is when you look at that group that is using non-medically for pain relief, you see that those are the ones that are much more likely to keep using at time 2 for non-pain relief reasons, that is to get high and to experiment. And we also see this with the substance use then at time 1 and time 2. For those who are engaging in the non-medical use of opioids to get high, that is for non-pain relief, it's statistically significant, and they are much more likely to have positive CRAFFT scores at time 2. And finally, study 5. Are there subtypes of non-medical users? So self-treaters, we believe, can best be described by characteristics previously associated with other forms of substance use, and they tend to be treating psychological or physical symptoms because they're self-treating. So what we looked at then was we looked at these centroids, and what we found is that the opioid group with the highest centroid were the medical users and the self-treaters, while the sensation seekers and the non-users were the lowest in this function. So if I go back here, what we can see then is that the predictor variables were highly associated with the second function, were those that were somatic complaints, anxiety and depression symptoms, and sexual victimization. So again, we're arguing that there do appear to be these subtypes of non-medical users. So in summary, this is the typology again that I'll remind you, and we do see some support for it, although certainly we need more research and we need bigger samples to look at it. We see in study 1 that medical misuse is prevalence. It's highest not necessarily with the opioids, but it is with CNS depressants. We also know that in our sample, those that are engaging in non-medical use tend to use other pills as well as just the opioids. Medical misuse is associated with significantly higher rates of substance use. Opioid analgesics are one of the most likely drugs to be diverted. Non-medical users of opioids get their controlled medications usually from friends and family members. Substance use differs by use as to whether you get high or whether you're self-treating. That shouldn't surprise us. And the CRAFFT can be used to identify subgroups. Non-medical use for non-pain relief at time 1 is associated with positive substance use scores at time 2, for those who are not using it for self-treatment. 1 in 5 non-medical users of opioids are endorsing their motivation for pain relief only, and 1 in 10 medical misusers at time 1 will engage in non-medical use at time 2. These are with their own prescription at time 1. They will engage in non-medical use at time 2. They're getting it now from some other source. And then there appear to be subtypes in non-medical users, with self-treaters having more somatic complaints, being anxious and depressed, and having a history of sexual abuse. When we compare them to the other group that appears more like what we would describe with externalizing behaviors. So there are 2 groups there. And finally, we have a lot that we need to understand. We need to understand the relationship between this medical use and non-medical use, and how it is that adolescents move from having a prescription and they get them readily, we've already heard that, and how they then move on to non-medical use, getting it from a friend. We need to understand the characteristics of diversion. We have a paper out that looks at stimulants, but bullying and those that have stimulants. Are those with their own prescription? Why are they diverting it? Are they diverting it for popularity? Are they diverting it for money? It doesn't look like it's for money. Are they diverting it because they're being bullied? We don't really understand why so many adolescents are diverting their own pills. But for every non-medical user, there's somebody with a prescription who is giving their pills away. And finally, the role of health providers. We must really think carefully, as we heard earlier, about how it is that health providers are prescribing to our adolescents. So I thank you very much for your patience and your attention. Thank you. These are the references. I don't know if we have time for questions.
Yeah, I want to make a quick announcement, which there are cards in the middle of the table. So if anybody has a question that they don't feel like personally standing up to ask, feel free to write it down and hold it up for one of the people moving around with microphones to read. Any questions? I have one, which is that we know that that at least with the way NSDA assesses it, which I have concerns with as well, but that misuse of prescription drugs is generally a lot higher in younger adults, but we know that a lot of the overdose problem is middle-aged adults. Do you have any sense of what, any thinking forward of the cohort of people who were young emerging adults as the access to prescription opiates increased? What do you predict for the future?
Well, I think that the data are clear that once exposed to an opioid analgesic legally, that is a risk factor for going on to becoming a medical misuser, obviously, but also a non-medical user later on. if we believe that non-medical users who are getting diverted pills are at risk for other forms of substance abuse, which means they're using other drugs that also put them as CNS depressants that put them at risk for overdose, and that they are more likely to increase their dosages, then yes, they're at risk. But I'm old, and I remember Teas and Blues and how Teas and Blues led then to a heroin epidemic. So Teas and Blues are Talwin, it's an opioid analgesic, back in the 70s. So my very first studies were with pills, Teas and Blues. And it led to a heroin epidemic and to an overdose epidemic. And then we swung back to crack cocaine. So, Amy, I think that what we're going to see is down the road, unless we control the pipeline, we're going to see more overdose in the older age groups, not in the younger necessarily. Thank you.